But we can go ahead and get started. And you know, I'm just really pleased about our SIPC seminar series. I am very excited about our two speakers today, Dr. Holly Prigerson and Dr. Katherine Ornstein. One of the reasons I'm so pleased is because this is really giving us a chance to find out about what's going on with palliative care across the city. And I'm hoping that this might encourage some collaborations across the city. So Dr. Prigerson is going to be our first speaker. She's the Sherwood White Professor of Geriatrics at Weill Cornell Medical College, Professor of Sociology and Medicine, and the director, I'm sorry, I just lost my place, director of the Center for Research on End-of-Life Care. She graduated magna cum laude from Columbia Barnard, where she received awards for proficiency in U.S. history and Spanish. She has a graduate degree in history and sociology from Stanford, a postdoctoral fellow in epidemiology of aging at Yale, and she received her honorary master's degree from Harvard. She was approved for tenure as a faculty member at Yale and Harvard Medical School, and was recently promoted to professor of psychiatry at Harvard Medical School. The theme of her research across studies has been examining psychosocial and behavioral influences on medical outcomes, medical care and care outcomes for patients and family, confronting life-threatening illness and death. Dr. Prigerson has served as a principal investigator on multiple NIH grants that focus on cancer patient and caregiver quality of life and disparities in end-of-life care. She's been the senior author on several landmark studies, including a study of the stages of grief, of outcomes of end-of-life communication, and effects of religious coping on medical decision-making and care near death, which was published in JAMA, New England Journal of Medicine, Journal of Clinical Oncology. Super. She just has done. She's also the 2012 National Hospice and Palliative Care Organization Distinguished End-of-Life Researcher Award. So very, very pleased to have Holly here. Please, Holly, begin.
Thank you for that very nice, accurate introduction. Pretty much, my final appointment is at Cornell, so I'm at Cornell now, and moved to Cornell in 2014. So I'm starting to feel like a Cornelian, as they say, but it's not too far from Columbia or even Mount Sinai. So if the goal of this seminar was to foster collaborations, it already has, because I think someone in attendance, I won't embarrass anyone, but we're already starting to think about some potential collaborations on one of the studies that I'll be talking about today, the Empower study. So without further ado, let me get going on the talk, because I'll be talking today about aspects of mental health at the end of life, which includes into bereavement, but my focus will be largely on the period around, immediately before, during, and after the death of a loved one. So I'll be talking about psychological responses to serious illness, dying, and death, the course of these psychological responses over time as people adjust or don't, predictors and outcomes of those psychological states and responses. And then I'll be presenting a snapshot of our preliminary work on enhancing and mobilizing the potential for wellness and emotional resilience of family caregivers of dying patients. That's a mouthful. We call it Empower, but that basically, you'll understand whom we're empowering and why, hopefully by the end of this talk. So this should be common to everyone, is what are psychological responses to death and dying? And I'm trying to move you guys because you're kind of blocking the slides. Okay. So it's obvious that people are worried, they're horrified often, they're frightened. Grief symptoms of yearning, disbelief, emotional numbness, and dissociation. Symptoms of depression, sad mood, guilt, regrets, helplessness, and hopelessness. Those are the constellation of symptoms commonly experienced by people who are dying, their family members, and bereaved survivors. So we did a snapshot. I have what you call an R35, an Outstanding Investigative Award. So that's fostered and sponsored a lot of smaller pilot studies that provide a lot of background work that justify the directions that we're taking some of this work. So we have what we call our SOS, our Severity of Suffering study, and our SOUL study about symptom management of patients and family surrogates in the ICU. And what we found in one of these studies, Heather Derry was first author on this study, is that there are enormously high rates of psychological distress in patients in the ICU. 93% being tense and wound up, 60% worrying, having worrying thoughts, 60% feeling sudden panic or blanking out, 80% saying that there were moments of extreme confusion, 85% feeling helpless, 100% felt sadness and grief. This is from the Peritraumatic Dissociative Experiences Questionnaire, and 100% were frustrated and angry. Now, there's a huge literature on PICS and post-ICU syndrome. Here, what we did an analysis that was just published recently. Heather Derry's first author on this, where it was a very, very small sample. I think it was about 15 people who we had a follow-up assessment of the outcomes of these psychological states a month later. And the Spearman's Row was 0.7 in just 15 people a month later. So basically, what our focus has been on is on peritraumatic stress. A lot of palliative care is focused on post-traumatic stress, which we say isn't really appropriate for these kinds of interventions because it's not post anything. They're in the middle of experiencing a lot and will continue to experience substantial psychological distress and trauma. Their family members do as well. And so we found that 57% had extremely high or found it to be very true or extremely true levels of sadness and grief. Over a third felt helpless, and about 30% felt also extremely frustrated and angry. They had that sense of derealization, the sense that things were happening in slow motion, which is an indicator of dissociation or peritraumatic stress. When we wanted to know correlates of peritraumatic distress and dissociation, which, as we've shown in the ICU, is similar to, we've done studies a long time ago of combat vets. And basically, Doug Bremner, he's at Emory now, but he had done some important, and David Spiegel at Stanford had done some important studies showing that basically peritraumatic stress and dissociation, the people who kind of blank out in combat, they're the ones most likely to get PTSD later on. So we're applying that kind of psychology and understanding to the context of ICU stays, critical care. And we're showing that patients, when the patients are younger, the family member is more likely to experience peritraumatic distress and dissociation. The longer the stay in the ICU, obviously the probably sicker and more exposures to which they're exposed, more traumas to which they're exposed, the longer the stay in the ICU. And the worse symptom burden of the patient is more upsetting and frankly traumatizing for the family member to see their family member so sick. We also find that communication increases the risk of making this a more stressful, enhancing the levels of peritraumatic distress and dissociation. So that's a prologue to where we're going with this later on in terms of surrogates who are in that position and the reasons why we think they're particularly vulnerable. So in terms of actual prevalence rates of mental disorders of the terminally ill, caregivers, and who become bereaved survivors, we actually find the rates aren't, they're higher than the general public, but they're not extremely high in the patients. So we find the most common mental disorder among patients is major depressive disorder at 7%, meeting SCID criteria. 3% generalized anxiety, worry, that sort of thing. 5% for panic, which was somewhat surprising because panic, by definition, has been defined in DSM as coming out of the blue. We find it doesn't come out of the blue. These dying patients actually experience significant panic, not always rising to the level of a disorder, but they have panic attacks about their impending death. As a personal example, my father was a physician who had pancreatic cancer, and he would wake up with sweats and having panic attacks in the middle of the night that we had to actually treat. So panic attacks happen in advanced cancer, not hugely frequently, but they're a fairly common occurrence, even if they don't rise to the level of disorder. But surprisingly, we're not the only group to find this. This has been pretty well established for decades, that PTSD is actually pretty low. Only 2% of the patients with advanced cancer met diagnostic criteria for PTSD. And about 12% met criteria for one of those disorders. When we compare the patients in red to the same race on the same diagnostic criteria in their family members, we find the same levels of depression, 7%, slightly higher for generalized anxiety of the family member. Panic goes up to 7.5%. The family members are in a position of being responsible for their loved one, making decisions. And PTSD is higher in their family members who are witnessing severe stress and horror of their loved one and feeling helpless to do anything about it. In other words, the criteria for PTSD. So it was somewhat surprising to us that the rate of PTSD was threefold higher in the family member than in the actual patient who was dying. Now, with respect to bereaved caregivers, so these are the same group, the caregivers followed to 6 months after the death. We found that the most common mental disorder, which we'll be defining soon, PGD, it was the most prevalent disorder at almost 11%. As you can see, most of the anxiety disorders drop. So PTSD went from 6 to 4% in these caregivers after the death. Generalized anxiety went from 4.5% to 2% after the death. Panic halved from 8 to 4%. Depression remained stable. So that all groups had 7% MDD, and PGD, prolonged grief disorder, was the most common reaction. It's actually surprisingly difficult to meet criteria for prolonged grief disorder, despite the common reaction that I get, which is these symptoms of yearning and pining, et cetera, which I'll be just describing, seem so normal after a loved one has died. The prevalence rates have been remarkably low, and I'll be discussing the symptoms, but I do want to share that the DSM has just approved prolonged grief disorder for inclusion, and ICD-11 has already included it, and we have a paper coming out with a scale that maps onto and validates the criteria that the DSM have proposed. So what are those criteria? So first there has to be, we start with the death of a significant other, a very close other. It's not the death of anyone. And that might seem so obvious, but there have been studies about resilience in bereavement, and it frustrates bereavement researchers to no end because you don't feel distraught after an aunt that you didn't really know very well dies just because she's somewhat closely kinship related to you. What the core risk factor for prolonged grief disorder is a very close, significant attachment to the person who died. So unlike normal grief, people with this disorder are stuck. I get emails like for years and years, for decades, sadly, of people who are stuck in this state of chronic mourning. It's this state of being numb, detached, not being sure who they are. and sort of just wishing that they could turn back the clock and crawl into a hole and wish it away, and that avoiding. So it's different from PTSD in that PTSD is avoidance of a threat. Here, the threat is the reality that this person's not coming back. So the avoidance is very different. It's more of a detached emotional numbness and fear of connecting and attaching to others because you've sort of been abandoned by the person that you have relied on. So this is this identity instilling source of security and closeness and understanding. That's the kind of relationship that poses a risk for prolonged grief disorder. So the criteria that were just approved are after 12 months have to have elapsed since the death. Now, there was a large debate about after 12 months, there are anniversary reactions, but what we're saying is it doesn't matter how you get to 12 months. So we've done studies where we compare people who have had high levels of these symptoms from the minute of the death until a year later. And we've had people who initially were just kind of shocked and numb and didn't, but then did have very high levels after a year. And we find that they both are pathological in different ways, and they affect sleep differently, but both lead to suicidal ideation and pose significant risks. I won't belabor it, but it doesn't matter how you get to being high on these symptoms, but 12, if you're high on them at 12 months, that's a problem. The core gateway symptom that they call is primarily yearning intensely. That's really what grief is. It's this yearning, pining, longing, craving for this person. And that's why we've done a recent review of the neurobiology of prolonged grief disorder and shown there's activation in the nucleus accumbens, that's the reward center of the brain. And we have a pilot that's actually capitalizing on that understanding to use naltrexone, which is for addiction. But we have some very, very preliminary findings suggesting that naltrexone is able to reduce the yearning and reduce the grief scores in people who are stuck in the state of chronic yearning. So yearning is the core symptom. 3 of the 8 following symptoms: identity disruption, disbelief, avoidance of reminders that the person's actually dead, emotional pain such as anger, sorrow, difficulty reintegrating into life, particularly socially, a sense of emotional numbness, meaninglessness, loneliness, and all these symptoms are associated with significant functional impairment. One of our studies that I thought was going to be the most benign, I wouldn't say nothing burger, but we removed people who met criteria for prolonged grief disorder. We were not trying to pathologize grief. We only wanted to look at what does normal grief look like, and does it look like Kubler-Ross suggested that it looked like, the DABDA model of disbelief, anger, bargaining, depression, and ultimately acceptance. So I'll show you the data from our test of it. But despite people vehemently objecting to this idea that grief progresses in a very structured, systematic, standardized way, people just have a knee-jerk response to this, saying everyone's grief is unique. It's like a snowflake. Everyone has their own path. No, there's certain truisms, and the data support. It's almost undeniable that the first initial psychological response to the news of a death of someone you loved is a shock and disbelief and emotional numbness, that this is the deer in the headlights, this can't be happening. So no one can deny that the first response when something awful like a death of a loved one happens is, or you get a diagnosis, no, this is too bad, this can't be. And so we'll show you the data supporting this sequence, followed by anger, bargaining, Kubler-Ross proposed for before the death. So it was bargaining, like, I'll stop smoking if you make my lung cancer go away. That's the negotiating to try to undo the impending death. That doesn't apply for the bereaved situation. Depression after you've resolved the anger. And then Kubler-Ross called it acceptance. And we think it's really more of resignation of what, that this is the way life is, that people ultimately come to accept or are resigned to facts of life, and that it's nature's way that people are born and then die. I keep this picture of the frog in boiling water because I wanted to convey the notion that people are very adaptive, but they can adjust to almost everything or anything. However, a very smart research assistant said, but the frog ends up dead. So we swapped in a later version of this slide, back in the saddle again of a picture of somebody on a horse, but not a frog who's dead in the boiling water. So what we did was we examined over time different levels of the 5 indicators of grief: disbelief, yearning, anger, depression, and acceptance. Those measures of grief in our Yale bereavement study a long time ago. And to shorten this talk, I don't present the absolute levels over time, but what we did was we rescaled the data to represent when does each of these symptoms, when is it maximally expressed? When does each of these symptoms peak? And it was exactly in the sequence that Kubler-Ross had proposed. When is disbelief most common? Initially. When is acceptance most common? Over time. When did yearning peak? 4 to 5 months. When did anger peak? 5 to 6 months. When did depression peak? About 6 months. So in terms of this is removing people with prolonged grief disorder. In terms of the normal course, it seems like there is some evidence that this sequence is on average how people psychologically respond to the death of a loved one. The likelihood that these 5 indicators would peak in this exact sequence was 0.008. So it was not by chance. Now, that's, as I've been saying, that's different than prolonged grief disorder. So this is a very old but very crude illustration. But what I wanted to get at in this plot was people often say, well, you know, everyone's upset initially, and if you just give these prolonged grievers time, they'll get over it and they'll adjust over time. And what we did was we diagnosed people who met our criteria. Here, actually, it's the 6 months criterion. And we wanted to know whether basically the red line would drop, the people who were high initially would fall off like the blue dots. And what we found was no, it didn't become purple. Like it was the people who we had picked out as being stuck at 6 months remained stuck for the observation period. So we're not prematurely or overdiagnosing people who over time will naturally adjust. There is a distinct group that even initially seems more disturbed. Okay, so what are the risk factors for psychological distress in these in patients and their caregivers? So here what we did was we wanted, the word contagion is inaccurate because it wasn't causal. This was a cross-sectional snapshot of the caregivers and the advanced cancer patients approximately 4 to 5 months before the patient had died. And so we call this mutuality and specificity of rates of disorder in patients and in dying patients and their family caregivers. the first thing that we found was that, of course, they're very significantly associated with each other. However, depression isn't. So, we think that people, when the patient is very depressed, meeting criteria for depression, that's 7%, the caregiver is not more likely to meet. So it seems less contagious in that way. Maybe depression is more internal, more of an internal struggle. But we haven't unpacked the reasons why, but depression was not associated with patients, wasn't shared. Anxiety was a lot. And especially, yellow highlight the caregiver's PTSD, which is hugely associated with the patient meeting criteria for PTSD, generalized anxiety disorder, and panic. So there's something, and their panic was also associated with generalized anxiety disorder in the patient. So the caregiver's anxiety and it's chicken and egg. This is cross-sectional. We're not making any assumptions about causality, but there is something to shared anxiety. That anxiety seems to as people are bouncing off of each other. And for the pandemic, this doesn't bode well. That panic-stricken, traumatized, anxious people engender living with other anxious people. So this is my one moment of audience participation. We wanted to know which of these exposures, scary exposures, significantly was associated with the caregivers meeting criteria for generalized anxiety disorder. So I'll read through very quickly all these scary exposures, and then I'll ask for a show of hands of which one you think is the most scary, for highest related to generalized anxiety in the family caregiver. Seeing the patient confused or delirious, witnessing pain or discomfort, feeling unable to eat or swallow or choking, vomiting, dehydration, insomnia, collapsing, feeling the patient had had enough, thought that the patient, walking into the room thinking the patient had died already, and caregiver burden, a separate assessment of just caregiver burden. So show of hands, confused or delirious. No one. Well, I don't think I see everyone, but if anyone's raising your hand, please.
There was 2 hands up there.
There are 2 hands. Confused and delirious?
Mm-hmm.
Excellent. Experience severe pain or discomfort?
2 hands.
2 hands?
3 hands.
3 hands.
4 hands.
Oh, 4. All right. Choking, vomiting, dehydration, insomnia, collapsing, feeling the patient had had enough, thought the patient was dead, and caregiver burden. All right. Well, this group actually did better than 2 or 3 different whole audience room full of psychiatrists. So psychiatrists didn't realize that confusion and delirium by far and away is the single most, it's extremely upsetting to the family member to see it. Even, a person might say, oh, well, what if they're they're delirious, but they're happy, or for whatever reason, we found that clearly was the most upsetting in terms of anxiety for the family member. Also, vomiting was significantly bivariately. Insomnia, for some reason, I don't totally understand that. Feeling that the patient had had enough, and caregiver burden. And then when we put them all in simultaneously, the only one that remained significant was delirium. So this also is a prelude to why we're choosing to focus on family caregivers of cognitively impaired or delirious patients who can't communicate. So hopefully these data have supported why we're focused on critical illness, and that it can put it, it puts patients and caregivers at risk for psychological distress. The burden's especially great for family surrogate decision makers of incapacitated dying patients in the ICU. And this has been further exacerbated by COVID social distancing, which frustrates and angers a lot of family members that they can't communicate with, touch, and have the contact that they wish they could with their dying loved ones. So there's a need to help these family caregivers cope with this extremely psychological distressing situation in the moment. So that's some of the innovation is in the ICU. So I'm not going to repeat the title. We're calling it Empower. It's a CBT acceptance-based intervention delivered by a trained social worker. So we're hoping it's scalable to informal caregivers in the ICU or via telehealth now with COVID. This looks very confusing. It really isn't. What we're saying is the patients in the ICU, they can't communicate for whatever reason. And this was in response to the director of the critical care unit at the MICU at New York Presby Cornell saying these family members aren't getting it. They don't get their family members dying. They're out of it. They're being hounded to complete a DNR order, and they don't know what's up. They need help. Our model is that we will empower them. I'll show you how. It reduces experiential avoidance, and enhances distress tolerance so that they can hear what's actually happening and engage in a role play. I'll go through the elements of it. That will increase rates of advanced care planning, which will increase rates of value concordant care, palliative care if you want it, more aggressive care also if you want it, not if you don't. And that we've shown that that's associated with better quality of life / in the last week of life or quality of death. And those exposures also relate directly to psychological outcomes in the caregivers. So if it doesn't go well, they're at greater risk of prolonged grief disorder, anxiety, and PTSD after the fact at a 1, 3, 6, and 12-month follow-up. But if without Empower, they have guilt, regret about the decisions that they made about withdrawing life support. So we're trying to address those psychological issues that are getting in the way of advanced care planning, as well as preparing them psychologically so they don't develop prolonged grief disorder down the road. So we basically get this surrogate decision maker with anticipatory grief, which is a very significant prodrome, even associated with prolonged grief disorder, as well as suicidality, et cetera. So we get them if they meet our threshold level, PG-12 is what we call it, and or have severe anxiety. We acknowledge that this is a potentially traumatizing situation. We normalize the event. We engage in mindfulness, breathing, and grounding exercises, provide psychoeducation about what peritraumatic stress is, anticipatory grief is, and pre-loss grief, and experiential avoidance. The part that they hate, they don't like it. They don't like doing this role play where the patient can't communicate, and we talk with them about what they imagine the patient would want, so that they don't have regret and guilt later on. But they admit after the fact, when we debrief with people after they've been quote unquote empowered, it was the part they liked least, but the part that they found most helpful in having them we're not pushing palliative care. We're not pushing that they sign a DNR. We are there to provide emotional support to help them make a decision that they're not going to regret. That's it. And we help them think through in a careful way what they think the patient might want. Okay, so and we say that should improve their mental health. Our pilot data, I don't know, am I running over? Pilot data we had an open trial and we're still enrolling for an RCT. Very strong effects on pre and post-loss grief, which are very associated with each other. Actually, most of them, the patient had died. It also was significantly associated with, decent effect sizes for anxiety and peritraumatic stress, and experiential avoidance scores were significantly associated with all the above, basically. So in conclusion, dying patients and their personal caregivers experience significant symptoms of anxiety, depression, grief, and peritraumatic stress. These symptoms mostly resolve over time as people come to accept and become resigned to the loss, but can predict enduring distress and disability. ICU hospital stays and deaths result in more psychiatric morbidity. Oh, I actually took out a slide that showed that ICU deaths threefold increase the risk of PTSD after the death. I was trying to save time. And that Empower is a potential solution to addressing the psychological issues that confront family members of dying patients. The end.
Thank you so much. We have a couple of questions. Tonda asked a question regarding your Kubler-Ross model, that it seems to fit unexpected deaths more than those associated with prolonged illness. Do you have any thoughts about that?
I do. One is, as someone who's been studying bereavement forever, I am a remarkable finding has been, even in the case of Alzheimer's, of being very aware that this person is dying for many, many years. I don't think there's a person who says that they weren't shocked or surprised when it actually happened. So denial's a huge thing, and I think this also affects, I think, interest in palliative care, and more specifically, hospice, which is people, even in the ICU, people are reluctant to acknowledge that someone that they love could actually be dying. It's just, and it obviously, the being shocked and stunned, and the rates of PTSD, and we've compared mode of death with these symptoms, and the main symptom that's different, aside from more shock if it's like from out of the blue that a young person got hit by a car, for example, is anger and rage. And in traumatic deaths, how could this happen? What kind of God would make this horrible event? Rage at the medical, lawsuits, but they're looking like, how could this happen? And in traumatic deaths, there seems to, for Alzheimer's, there's less of how could this happen. You see how it's happening. There's denial initially, and they're still shocked when they actually do die. Just like with Ruth Bader Ginsburg, some people are like, I was shocked that she died. I'm like, really? So I was kind of shocked that she hadn't died yet. But so I hope that answers Tanda's question. But it seems like rage is very different. But in terms of prolonged grief disorder, mode of death is not a very strong predictor of rates of prolonged grief disorder. It is a very strong predictor, obviously, for PTSD.
Thank you.
Thanks. I think it answered it, Tonda.
Yes.
And there's a couple of other questions. May asked, the pilot data for Empower looks very impressive. Can you speak a little to why this intervention may be effective when others in this arena have not shown differences in psychological outcomes, such as the Poppy trial?
I don't know which one's the Poppy trial, but I know the Carson trial and a few other trials. It's been remarkable lack of effects on PTSD, for example. That's using like the IESR. one hypothesis that we have is they've been, so for example, in the JAMA 2016 Carson study with Judy Nelson, that was a palliative care intervention in the ICU. There have been concerns that it wasn't a complete palliative care, it wasn't a good enough palliative care intervention. We were not surprised because palliative care physicians are not trained as clinical psychologists or therapists, and these are psychological issues. And if you're not trained, it's almost insulting to think that people who don't have training in addressing peritraumatic stress or using CBT-based interventions to target experiential avoidance and distress tolerance or intolerance as a barrier, which is a very well-established technique for reducing post-traumatic stress disorder, targeting symptoms of the prodrome, peritraumatic stress, and that dissociation, so enabling them to tolerate that and not space out so that they can actually hear and benefit from an intervention. We think that the components of Empower are to target and use proven, I mean, these aren't novel techniques. These are extremely well established techniques, but these other applications have not used those techniques. In what they call a palliative care intervention, they're not psychological intervention.
Thank you. Holly, I hope you have time to stick around. There's questions in the chat box that maybe you can address, but I think we should go on to Katherine and make sure that we have enough time for everybody. So I hope, because there's some really good questions, and in the discussion I'm sure will be good, but let's do it on the chat, and let's listen to Dr. Katherine Ornstein. Katherine, are you pulling up your own slides, or? Okay, you're on mute.
I'm on mute. I can as soon as Holly stops sharing, I can share.
Okay, so Ashley and we'll take care of that. Okay. So as we're pulling up the slides, I'm really pleased that Katherine Ornstein is presenting. She's on faculty at the Icahn School of Medicine at Mount Sinai in the Department of Geriatrics and Palliative Medicine and the Institute for Translational Epidemiology. Her research interests include caregiving, symptom burden, and home-based primary and palliative care. Her current work applies to the social epidemiologic framework to palliative care research by linking existing national and international databases to determine how treatment intensity, including hospice care, for patients with serious illness impacts the health and healthcare utilization of family members. So take it away, Katherine.
Okay, thank you for that introduction. And I will start, as many Zoom meetings starts, with, can you see my slides?
Yeah, we can see your slides. We can also see the things on the side, so it's not in...
oh, okay. Let's do it from... how about there?
Perfect.
Now I can see them too, even better. Okay, fabulous. Thanks so much. It is a thrill to be here, and especially to be on a panel with Dr. Prigerson, who, as you'll see, has had a huge influence on my work. I'm a big fan, so I'm very excited to talk to you today about something that I've been working on for a while, which is sort of just really thinking about how healthcare delivery is changing at the end of life. And really part of that is really thinking about how the family needs to be really more and more a part of how we even just think about healthcare delivery in general. So first I'm gonna talk to you about the landscape of the changing landscape of end-of-life healthcare delivery, and then specifically share some research we've done just documenting the end-of-life caregiving experience. I'm an epidemiologist, so I like to present numbers and describe what's happening. And then I want to talk to you about how the end-of-life experience impacts families over time, and ending with what I think of as some important new approaches that I need to take and I'm working with colleagues on to really advance caregiving research. So as most of you probably know, Americans are increasingly dying at home. This report came out in 2019, which seems like a lifetime ago, but really showing that for the first time we are seeing home deaths more common in the US, and this is really a huge difference. You can see this orange line over time increasing. And similarly, we see that hospice use, and this is a big, ugly, complicated slide with actually a lot of very important information from Joan Tino and her group. But what I want to highlight here is hospice use has increased tremendously. We can see here in the fee-for-service Medicare group, more than half are using hospice, and this is huge in 15 years from 21%. So this is tremendous growth. I will highlight at the same time that this is amazing trend is happening. ICU utilization in the last 30 days has actually increased. So we are not seeing a reduction there. So sort of interesting, contrasting findings. And I'd also point out that there's a lot of work now that's being done looking at assisted living facilities and other community-based residential settings. And this is work that we did at Mount Sinai, really looking at where people are dying, living in these settings. And increasingly, they're also using hospice more too. So we are seeing about 10% of individuals are dying in assisted livings or similar kinds of communities. They are also using hospice in these settings. And finally, work that I've been doing for a long time is actually focusing on individuals who are living at home, receiving home-based care. And so what we've done is a lot of work to try to understand how many older adults are actually at home and are homebound. And by homebound, what we mean is that they really never are able to leave the home, or really very rarely, or it's extremely challenging to do so. And we did a prevalence study of this many years ago and found that 2 million older adults in the US are homebound. And what's important about this is that's actually larger than the nursing home population. And we most recently updated this work with an incidence study to actually look at older adults living in the community and to try to see, are they more likely to go into a nursing home or to become homebound? And indeed, what you can see here on the bottom left, are you all seeing my pointer moving around? I move it a lot. Okay, I'll try to keep it a little more still. But you can see here in the blue, is this showing a cumulative incidence over time of individuals becoming homebound. Relative to the blue, you see this much smaller orange line, and that's individuals going into nursing homes. So indeed, we are seeing this trend happening over time, and this is, these are data sort of even before COVID, which I believe indeed will be changing the landscape of how individuals decide to age at home. And relative to this, I'll put in sort of a brief but relevant plug for the work that we're doing at Mount Sinai. We sort of have a clinical programs at Mount Sinai that we call Mount Sinai at Home, which is actually a portfolio of home-based services. And this is sort of interesting that a hospital, essentially now a health system, is actually, trying to impress people with home-based care, right? And we've been doing home-based primary care at Mount Sinai for many years, more than 2 decades. We now have home-based palliative care services. We now have hospital at home services, community paramedicine services, as well as rehab at home is sort of what's happening, trying to get it going again. So there's really a move to sort of provide services within the home for individuals at different stages. And our Institute for Care Innovations at Home is actually sort of the research arm of this, really trying to understand how this impacts individuals and to evaluate and disseminate this work. So related to that, most of my work has really been impacted by thinking about the family's role in end-of-life care. And this report I often turn to as still being very relevant, which is really highlighting that in end-of-life care, there's a huge demand on families, and that good care at the end of life should be family-oriented, and really consider the needs of the family and caregivers throughout. At the same time, we recognize this in the delivery of end-of-life care. We also recognize that there's just an increasing role for families throughout the care of seriously ill individuals, including the end-of-life period. So this report that came out 4 years ago from the National Academies of Sciences, previously IOM, didn't actually tell us anything we didn't know. Or I think many of us in this field, like, we recognize this, right? They're really involved in this care. But I think what was so important about this is to really see it very clearly and to put it out there that, in fact, this is a public health crisis, essentially, of individuals who are serving in this capacity unpaid, who are tremendously burdened, have a lot of responsibilities, and their own health, mental health and physical health may suffer, as well as significant impact relative to their own financial burdens as well. So with that, I will pause and show you some data that we used. In thinking about end-of-life caregivers, I felt struck by the fact that, well, there's a lot of work around it, but how many are there and who are they exactly? And it turns out I couldn't find a really good answer from a nationally, so I set about to look at it myself with some colleagues. And we used the National Health and Aging Trends Study, a publicly available data set funded through the NIA. And what we did here was actually just what they do that's really nice is they ask individuals who provides help. And so that allows us to see not just if they have one person helping, but you can actually see multiple people that may be helping. And we looked at individuals who we saw died within a year. And we then looked to see, well, who was helping them and what were they helping them with, essentially. So we found that there are more than 2 million unpaid caregivers assisting individuals at the end of life. And importantly, and I'll talk about this later, the majority of them are not spouses. Only 14% of them are spouses involved in end of life care. Also importantly, we see that they're actually doing a lot. Here is differences comparing caregivers by those at the end of life where their care recipient dies within a year versus those where they're just serving as a caregiver, but their care recipient does not die within a year. And you can see here that there's more work happening relative to providing assistance with personal care, doing things such as transportation, making the home safer, and things that I think are kind of really interesting and important, such as helping to find someone, a paid helper is also pretty important. I think what's interesting too is there are no differences, right? So when you're a caregiver, it's hard whether or not the person is dying soon, and things like health system logistics is something that's really most caregivers are involved with, making appointments all the time. That doesn't really vary. But we do see a high level of strain in end-of-life caregivers, more so than caregivers who are not working at the end of life, particularly around things around feeling exhausted or physical difficulty. We specifically looked at this among dementia caregivers, and not surprisingly, we saw things such as physical difficulty being really high in that group. But again, I would point out in some ways the lack of difference between end-of-life caregivers and non-end-of-life caregivers, for lack of a better terminology, is actually most interesting to me. We also did some work following this to look at not just who the caregivers are, but how are they functioning, essentially. And this is data from the Health and Retirement Study. And here we looked at spouse caregivers. And the reason we look at spouse caregivers is because the Health and Retirement Study conveniently surveys individuals' partners or spouses if they are included in the survey. So that's just the survey design. That allows us to do a lot of research with HRS looking at impact of end-of-life care on spouses. And we can link spouses and spouses' Medicare claims data. So that's why we were able to study spouses really well in HRS. And what we found here is that when an individual is in the last year of life, the spouse is actually more frequently than not caring by themselves for their loved one. So here in this first bar, we see looking at individuals whose spouse dies, that in the blue, we see that more than 50% are solo. No one else is assisting with activities of daily living. Not everything. We didn't ask about certain kinds of support, but really much of the hands-on tasks. And that includes anybody paid or unpaid involved. There is an important group here that are not involved in caregiving. I think that's something really important to think about relative to assumptions we make about spouses' ability, role, desire, potentially to be involved in care. I think what's interesting is we looked at some gender differences here. Women were more likely to serve by themselves. I think more of an interesting story here is that a whole lot of male spouses were serving by themselves as caregivers. And we even saw this happening when we could see that they had children living close by. And not surprisingly, those with dementia were less likely to serve by themselves. It just likely was impossible in the community setting. So with that background, I want to talk a little bit about work that I've done looking at how healthcare delivery ultimately impacts families. And I want you to think about it relative to a changing landscape of how we are delivering end-of-life care, thinking about how this ultimately may impact families. So a lot of this work came from this model I developed as part of my K Award many years ago, but really thinking about how the downstream effects of end-of-life care on families. And it continues to guide me, surprisingly, but allowing me to think about really how healthcare utilization ultimately may vary for a family relative to the patient's experience, as well as their social connections, and things such as the treatment intensity and how this may ultimately matter for family members, things such as symptoms and suffering, and how this can actually change their own healthcare needs. So some of the first work we did on this was looking at hospice use, and this is a lot of work using the HRS study. We found that spouses of individuals who used hospice, we created matched groups using propensity score matching of hospice users and non-hospice users. And here we found an increase, those who used hospice were more likely to have a reduction in depressive symptoms. This didn't quite reach significance in terms of clinical depression, but we really saw hospice as moving in the right direction, at least for individuals or for the families. Similarly, we followed up this work looking at specifically the use of life-sustaining procedures in the last month of life. So we looked at sort of intubation, artificial nutrition, individuals who received this in the last month of life. How did this impact depression for their surviving spouses? Again, we did some very elaborate matching techniques. And again, we saw that a negative effect of the ICU, most often these occurred in the ICU, but the use of these life-sustaining procedures. We looked at these among all spouses in general. We looked at these among spouses who were primary caregiver spouses. And we specifically looked at these among the population of spouses who did not enroll in hospice. There was no hospice use. And similarly, we saw that the experience of the patient ultimately impacted the depressive symptoms for the spouse. Moreover, and this was something I was really interested in, is actually seeing if there were cost implications for this. We spend a lot of time, even if we think we don't care about cost, even if we're not an economist, we still think about high costs of end-of-life care because it gets a lot of attention. There's a lot of concern around it, and it is a period of high spending. And we hypothesized that we would see higher spending in spouses that experience more intensive death experiences for their loved ones. And indeed, we did see that increase over time. I'll sort of talk you through it a little bit, this slide, but this red line is sort of a lineup for a period of death. Or the point at which an individual died. And here to the left is sort of the period before death. And here to the right is the period after death. And we looked at it in 3-month intervals over time. And the red is the group that had not a hospital death. So that was sort of the less intensive treatment and the blue is sort of a higher intensive treatment. Those are in-hospital deaths that occurred. And what you can see here among the spouses who survived, we see that among the in-hospital death, we see higher spending over here. And we actually looked at this in a lot of different ways. We looked at among those who spend higher in general. We adjusted for many factors. So, this I think is really important because it really helps us think about some of these downstream effects of costs of the end-of-life experience, not only for the critical mental health and physical health of the caregiver, but also actually thinking about what this means when we're modeling costs of care. So with that, I want to sort of talk about some new directions I've been going in. And one is really struggling with assumptions about family caregiver availability. And I think I alluded to this. And I think as someone who does research around caregivers, I'd like to say I also speak for the people who have no caregivers. And I think this is important to sort of pause and reflect on whether that exists. And I'm going to show you some research. We started to look at this and try to understand who these individuals are and how that may ultimately matter for their own experiences at the end of life in particular. And I also struggle with my own research that's very focused on spousal caregivers. And so much research is on spousal caregivers, and I am my biggest critic by far. And I really struggle with this, seeing that spouses are not the primary caregivers. They're very important in caregiving, and they play, and they have actually some of the most negative health effects related to caregiving, but they're not the only caregivers. Also, and as I've started to do research around cost, I think it's really important to think about more complete healthcare utilization. So when we're really trying to look at how caregivers may be impacted and ultimate cost modeling around it, a lot of the work I do, at least, is very limited to Medicare, fee-for-service data. So really looking at older caregivers that have Medicare. So what can we do beyond that? So I'm going to give you a little glimpse of what we've been doing around it. First of all, I have a student now working on a project where we've examined kinlessness at the end of life. And kinlessness is a little bit of a challenging term. Here it's sort of thinking about a traditional kin. Children, spouses are sort of often thought of as traditional kin that individuals have. Here we looked at, via the HRS, what individuals have at the end of life, so at the period they die. And what we found here, which is important, is if we look at those who have no children or spouses, that's about 5 to 7% of individuals at the end of life in the US. And then if we really look even deeper, we still see 1 to 2% of individuals with no children, spouses, parents, or siblings at the end of life. Now, of course, there are differences related to gender around this, and that's a whole other research topic around gender differences in this, but obviously related to spouses. Again, this is important. Women, for the most part, do not have spouses at the end of life. Similarly, we've done some work, and this is another student I have who just published this work, but actually trying to understand how the caregivers themselves may be instrumental in the type of care an individual receives. So in some ways, you can sort of conceptualize caregivers as sort of a social resource, essentially, which enables a patient to get good care, highest quality care. Here we did some work with the National Health and Aging Trend Study, NHATS again, and we actually looked to see whether or not having family caregivers facilitated hospice. And you can imagine that obviously we would think about whether someone can be at home based on the availability of family. It's not supposed to be a limitation, but certainly it's a logistical factor in hospice care delivery. What we found here is for individuals who died with cancer, we did see an effect, and when we modeled it, we saw an effect that those who had the most caregiving support before they died were more likely to have hospice at the end of life. And so I also want to address some of the issues that I've had in looking at families and limiting to spouses and limiting to Medicare data around costs. And that's why I go to Denmark a lot, well, not lately, but I have a research project there for a number of years where we've been looking at, and first of all, every epidemiologist loves Nordic countries because they're really good at data collection and they have everything linked, and they've been doing this for a long time. So we've been able to use Denmark to actually link individuals who've died to all their family members. And also in Denmark, they actually have a great palliative care registry. So you can actually look at that as well in their data, and it's really nearly 100% complete data for individuals. And very importantly, there's a universal health coverage, so you're not missing people. If you look at utilization data, you actually are getting utilization data. So just to kind of show you, this is sort of to give you a sense, you know, we're capturing 400,000 deaths in Denmark. And then we were able to link them. We find out everything about their treatment experience at the end of life. Then we link them to spouses, to all their adult children, to all their adult grandchildren, their parents, their siblings. And then what we've been doing is looking at utilization for the family before death, utilization for the family after death. Now, again, these are registries, so they're not surveyed. So we don't know about the relationships, we don't know preferences for care, but simply all the healthcare utilization. So just some of the fun stuff we've been doing with that, and I don't think this is showing up so well here, but we've actually been looking at kinlessness in this population, and here we're looking at grandchildren and siblings. And in Denmark, which again, different society, demographically different, but potentially a direction we're moving in more demographically, I would say, in terms of family size. We see that kinlessness is an issue, less so with individuals with cancer, but more so with individuals who are dying of psychiatric illness, right? Something we need to think about when we think about what our long-term care system looks like and what our plans are to support individuals. I jumped ahead. So similarly, this is a study that we just published in Denmark, just to give you an idea of what we're able to do, where we looked at the use of new antidepressants. And here, what we did is we looked at individuals when they died, and we linked them, in this case, just to their adult children, as well as male and female partners. And what we found here, and then we looked for new antidepressant use. They had never had it before. They were prescribed it, and they're really good at medication tracking in Denmark. And anyway, adult children are not impacted at all relative to new antidepressants. We see no evidence of it, no gender differences. But in fact, for partners, indeed, we see this period after death, new antidepressant prescriptions. So we have a lot of other projects underway using these data right now. And I'd also say, as I presented work about Denmark, I've met some colleagues from Utah who said, you know, we actually have a lot of good data like this in Utah as well. And in fact, they do, where they've kind of collected data in a lot of the same ways. They have data sources they've put together. In addition to having CMS data, they have data from Intermountain, which is like a Kaiser Permanente system of care. So they really have a lot of utilization data. So we're currently working on this now to sort of looking at family healthcare utilization relative to the end-of-life experiences. So just in conclusion, as we move to home-based care, I think it's great. I support it, but I do want to pause and make sure we're really considering caregiver outcomes and what we're asking for caregivers in the process at the same time. I think we need to make sure that everybody has access to high-quality end-of-life care, and that's a broader issue of equity, but in particular, people who don't have family, they're extremely vulnerable, potentially, and we need to make sure that they can also access the care that they need. And that, you know, myself and many colleagues, we're continuing to use population-based data registers to really have a broader understanding of the end-of-life care, end-of-life experience. And I myself am sort of moving beyond sort of more traditional dyadic research in this process. So it's very fun. I just want to acknowledge my funders, some of my amazing colleagues and team at Mount Sinai, my father, who taught me a lot about caregiving, and I still serve as his caregiver, and it's a joy, and thank you.
Thank you, Katherine. That was fabulous.
There's a couple of things. Feel free, type in questions or just ask questions. There's not that many. One of the things I wanted you to know is that at SIPC, we actually have a collaboration with the Visiting Nurse Services of New York. Margaret McDonald is from there. And Jingjing Shang, our co-MPI, is doing a lot of home health work and moving into palliative care. So it seemed very, very relevant to that. And maybe a collaboration will develop, who knows. But any questions about this? The other thing that, for me, you've probably met Bevan Cohen. Mm-hmm. And one of the things that SIPC did, she tried to put it in for a supplement. She didn't get the supplement. She got almost a perfect score on her R21. But you talked about her in needs grant. It's almost like kinlessness, but it's Bevan. You talk about your in needs, or if any questions. She's not on. Well, she just said she agreed. But what she's looking at is those.
Sorry.
Oh, that's okay.
I'm so sorry. I unmuted myself. I unmuted myself on my phone, but not the computer, and I was talking to myself. Sorry. But yeah, Catherine, you and I have talked a little bit about this offline, but I was thinking the same thing when you use the word kinlessness, because that's really the concept that we're getting at of not really having anyone in your life, not just actual, biological kin, but anybody else in your circle. And for the in need study, we're adding on to that and not only being kinless, but also not having any advance directives. So not letting anybody know your own wishes if you don't have anybody in your circle to let them know. So yeah, much of what you said, I'm so interested. I hope we could talk further.
Sure.
Any other questions or talk or thoughts? Go ahead, Holly. You're muted. There. Still muted, Holly. There you go.
How did you even know that I was talking? Because I just moved around a lot. Well, we haven't discussed any of the impact of COVID on how that may be affecting the length of caregiving, the location, home caregiving, kinship relationships, and people with young adult children moving back home, already using the vacant bed. Or it just seems like there's a lot that's happened over the last few years that will dramatically change the face of caregiving and the challenges of it. Another related challenge would be the opioid epidemic, and we've started looking at those bereaved by accidental overdose or not so accidental overdoses, and how you care for someone who's survived that kind of situation where they're not necessarily terminally ill, but it's a long commitment to caregiving that requires a lot of family member support. And so I'm just thinking of like current trends. Usually we think of later life, NIA, dementia caregiving, but now it's kind of exploded to be a whole other types of caregiving that we need to consider the implications of on the family member. So I would just throw that out there to.
Yeah, it was, hi, this is Margaret from, Pat just mentioned from BNSNY. Holly, we've talked on the phone before. Nice to see you. Catherine, nice to meet you. And I would encourage, we have a couple colleagues, clinician colleagues from our hospice program on the line, so if they should feel free to speak up as well about their recent experiences, which, as you can imagine, have been pretty intense. It was an interesting thing I heard from one of our hospice colleagues, a little bit of an unintended positive consequence of some recent experiences. We hear all the negatives, but there was something a little positive, especially in the caregiving arena from our spiritual care counselors, some of them anyway, and social workers. They actually had more contact with some caregivers during this time frame because they were doing more virtual, they were allowed to do more virtual visits. So their time allotments with going from place to place, it was less travel time and more time on the phone and communication between the person who is dying as well as the distant caregivers. So of course, telehealth was only temporarily approved to be able to be used, and there's going to be advocacy to try to solidify some of that. But it was interesting from the comments from some of my colleagues.
Yeah, actually, Jenny Mack, a pediatric oncologist up at Dana-Farber, we developed the a scale that in Mexico City they've been ravaged by COVID, and so we're collaborating on a study with them and adapting the scale. So Jenny and it was all focused on how COVID might adversely affect the therapeutic alliance. And Jenny's response was exactly what yours was, Margaret. It was, there are some silver linings. She's like, I get to spend like an uninterrupted hour with a parent that I wasn't able to spend before. So she's like, it's not all bad. Yeah.
Yeah, I would echo that and say in our home-based primary care program, the Mount Sinai Visiting Doctors program, we've been doing a lot of research just understanding what occurred during COVID with sort of the challenges and the disruptions in care. And indeed, telehealth has really been just really a real silver lining there. And we're hopeful around sort of the long-term use of it. And we actually just got a foundation grant to have community health workers help us to use telehealth more with our patients, because what we're finding is, as our patients, many of our patients are alone and they cannot use, even if we give them, and then we have another grant that we got to give people devices, well, they cannot use them. And the caregiver may not always be able to use them. So we're really trying to work to sort of we think expand the practice by using telehealth. And so we're, that if that becomes more normative, and for many of our patients who are extremely challenging situations, they're doing it, but we're actually going to be using a community health worker to help with telehealth so that we can actually provide more care for our program. So hopefully silver lining in that capacity.
Yeah, that seems like it would be especially relevant to the kinless.
Yeah, exactly. But even, what we're finding too with many of our patients, they're using, when we were doing telehealth visits, they're using their paid caregivers, right? And they're using their phones and their plans and their, so there's really lack of consistency there and sort of concern, but really exactly. But for many of our patients, the families have not been there for a while. They're very distant and they continue to stay away from the family members, even in 6-7 months already that we've been in this.
Any other last comments? I'm pleased as punch. I really want to thank both of our speakers. These were excellent presentations, just very, very fabulous. And I do hope there's some, increased collaboration that comes out of this. I hope you both will come to our next ones. Jean Kuttner will not be speaking in November. She was online. We did have a scheduling snafu, but she is going to become speaking in March. I think we've got it scheduled. So we'll be sending out links. Ab Brody is going to be speaking. We do have, we're going to, in May on Nurses Day, we're going to have Billy Rosa and Felicia Knoll speak, and we're going to have a poster session. So we'll be advertising all of these things. And I do hope you'll please, we're in Zoom land. We'd like to get palliative care researchers together. Please, share broadly and thank you so much. I really appreciate it. So, thank you.
Thank you.
Bye-bye.